Welcome to the next part of our glaucoma series. In this section, we'll be diving into chapters 3 and 4 of the BCSC glaucoma textbook, which focus on the clinical evaluation of glaucoma, specifically history taking and diagnostic imaging. By the end of this lecture, you should feel confident in integrating patient history with clinical and imaging findings to make more informed decisions in glaucoma care. Let's get started. Let's begin this section by reviewing the key elements of the clinical evaluation for glaucoma. As shown here, accurate classification of glaucoma is essential as it directly influences both treatment strategy and prognosis. The process starts with a detailed ocular and systemic history. This includes identifying risk factors like older age, African, Asian, or Hispanic ancestry, and a family history of glaucoma. These background factors raise the pre-test probability of disease. Beyond that, gathering information on the systemic medical history is equally important. Conditions like diabetes or vascular disease may impact both the disease course and treatment decisions. And don't overlook medication use, especially steroids, which can elevate intraocular pressure and potentially worsen glaucoma. We also need to assess the patient's quality of life. If a patient is already experiencing functional visual loss, early referrals for low vision rehabilitation or even surgical intervention may be necessary to preserve independence and safety. Altogether, this initial evaluation helps create a roadmap for both diagnosis and personalized care. Building on the previous slide, let's go deeper into the clinical history component of glaucoma evaluation. Effective glaucoma management starts with identifying the type of glaucoma, the severity, and how likely it is to progress. These factors help tailor the approach to each patient. The evaluation begins with a thorough review of ocular and systemic history, often supported by medical records when available. This includes pinpointing classic risk factors such as increasing age, African, Asian, or Hispanic ancestry, and any family history of glaucoma. We also focus on the patient's medication history, particularly any exposure to corticosteroids, and consider systemic illnesses that might influence intraocular pressure or optic nerve health. Lastly, if a patient's quality of life is already impaired by visual loss, that may signal the need for more aggressive treatment, whether it be referral for low vision services or even surgical intervention. Now, let's go into more detail with the next slide, which covers demographics, symptoms, and ocular history, key elements that help us evaluate glaucoma risk. First, age and ethnicity play a significant role. Older individuals are at higher risk, and ancestry matters too. African ancestry is linked to primary open-angle glaucoma, Asian ancestry to angle closure glaucoma, and Scandinavian ancestry is associated with pseudoexfoliation glaucoma. A family history of glaucoma increases both the likelihood of disease and the potential for severe progression, making it an essential part of your history taking. In terms of symptoms, we have to remember that most glaucoma, especially open angle, is asymptomatic in the early stages. On the other hand, angle closure can present with acute symptoms like eye pain, halos around lights, or blurred vision. The ocular history is also crucial. High myopia raises the risk for open-angle glaucoma, while hyperopia increases the risk of angle closure. Prior ocular trauma can lead to late-onset glaucoma, and past ocular surgeries like LASIK, cataract surgery, vitrectomy, or corneal transplantation can alter intraocular pressure or contribute to secondary glaucomas. Each of these elements helps build a profile of the patient's risk and guides further testing and management decisions. As we continue our overview of the clinical evaluation, this slide focuses on systemic diseases, medication history, and the importance of reviewing prior records. Let's start with systemic diseases linked to glaucoma. Conditions such as migraine and vasospasm are associated with normal tension glaucoma. Sleep apnea, cardiovascular disease, diabetes, and thyroid dysfunction, especially when associated with high episcleral venous pressure, may increase glaucoma risk. Respiratory conditions like asthma and COPD are especially important because they may limit our treatment options. For example, beta blockers are often avoided in patients with asthma or COPD due to the risk of bronchospasm. Additionally, systemic hypotension, especially nocturnal dips, can contribute to optic nerve perfusion issues and may accelerate disease progression, particularly in normal tension glaucoma. Moving on to medications, a number of systemic and topical drugs are relevant. Corticosteroids are well known to raise intraocular pressure and can lead to secondary open-angle glaucoma. Topiramate is associated with angle closure via ciliary body effusion. Anticholinergics may also precipitate angle closure in predisposed patients. And systemic beta blockers can blunt the effect of topical beta blockers. A sulfonamide allergy is important to note as well, because it raises caution when considering carbonic anhydrase inhibitors like acetazolamide or dorzolamide. Finally, don't underestimate the value of record review. Previous IOP measurements, visual field data, and optic nerve assessments provide crucial context for evaluating progression. If the patient has had poor control despite maximal therapy, always consider non-adherence as a potential cause. As we round out the patient history and background portion of the evaluation, it's important to zoom out and consider how glaucoma affects the patient's daily life and the broader context in which they live. Always ask about the impact of disease on activities of daily living, such as driving, reading, or even participating in social activities. These are not just soft metrics, they can guide us toward more aggressive intervention if the disease is interfering with function. Side effects from medications like ocular surface dryness or redness may significantly reduce adherence, especially in elderly patients with other competing comorbidities or limited support. If a patient reports a decline in quality of life, even in the absence of major structural changes, this could warrant referral for low vision services or surgical intervention to improve function. And in patients with advanced glaucoma, subjective visual complaints may be one of the few reliable indicators of progression, since structural and functional reserve is already limited. Finally, we must not overlook the social determinants of health. Issues like transportation, financial barriers, health literacy, and social support can significantly impact disease management. A patient's inability to afford medications or attend regular follow-up can derail even the most well-crafted treatment plan. Proactively identifying these barriers can help us tailor our recommendations more effectively. Now that we've covered the history and background that inform our glaucoma diagnosis, let's shift our focus to the anterior segment examination, one of the most important components of the clinical evaluation. A systematic anterior segment exam, including slit lamp biomicroscopy and, critically, gonioscopy, is essential for accurately diagnosing both glaucoma and ocular hypertension. It's not enough to just identify elevated IOP. We must be meticulous in detecting angle closure or secondary causes, such as pigment dispersion, pseudoexfoliation, or uveitic syndromes, which may otherwise be missed. Additionally, anterior segment imaging modalities, such as anterior segment OCT and ultrasound biomicroscopy, can enhance our assessment of angle anatomy, iris configuration, and other structural changes related to glaucoma. These tools can be especially helpful when the view is limited or when subtle findings need to be documented and followed over time. This anterior segment evaluation, when done thoroughly, can be the key to making the correct diagnosis and avoiding mismanagement of a patient with glaucoma or ocular hypertension. In this slide, we focus on the role of refractive error in glaucoma evaluation and risk. Accurate refraction is crucial, not just for prescribing glasses, but also for ensuring reliable visual field testing, since even small, uncorrected refractive errors can skew threshold perimetry results. Let's talk about risk associations. Both myopia and hyperopia are linked to different types of glaucoma. High myopia is associated with increased risk of primary open-angle glaucoma. Meanwhile, hyperopia is a well-known risk factor for primary angle closure due to crowded anterior segment anatomy and shallower chambers. But the relationship doesn't stop there. Myopic eyes can have tilted or anomalous optic nerves and large discs with peripapillary atrophy, which makes it more challenging to assess glaucomatous damage. Additionally, pigment dispersion syndrome, a secondary cause of glaucoma, is more common in moderate myopes, particularly young males. On the other hand, hyperopic eyes tend to have smaller optic nerve heads, which can falsely reassure the examiner or lead to underestimation of damage in early disease. So always interpret optic nerve and visual field data through the lens of the patient's refractive error.
Evaluate the ocular adnexa for conditions associated with secondary glaucoma or complications from treatment. In tuberous sclerosis, angiofibromas on the face and eyelids can lead to glaucoma from vitreous hemorrhage, neovascular glaucoma, or retinal detachment. Juvenile xanthogranuloma presents with yellow-orange papules and may also lead to glaucoma. Oculodermal melanocytosis, or nevus of Oda, causes blue or brown discoloration around the eye and is glaucoma-associated. Neurofibromatosis type 1 can cause eyelid plexiform neurofibromas, with glaucoma present in 25 to 50% of cases with eyelid involvement. Lastly, elevated episcleral venous pressure, seen with port wine stains in Sturge-Weber syndrome or in Klippel-Trenaunay-Weber syndrome, can contribute to glaucoma due to vascular anomalies.
Continuing with our evaluation of the ocular adnexa, the next focus is on vascular and structural disorders that may lead to secondary glaucoma. Orbital varices, arteriovenous fistulas, and superior vena cava syndrome all raise episcleral venous pressure, which in turn increases intraocular pressure. Clinically, look for signs like unilateral proptosis, dilated episcleral veins, orbital bruit, and chemosis. These external cues can point you toward a vascular cause of glaucoma. Thyroid eye disease is another important contributor. By elevating episcleral venous pressure, it can similarly lead to secondary glaucoma. You may observe exophthalmos, eyelid retraction, or restricted ocular motility in these patients. These conditions remind us to always consider orbital and systemic contributors when the glaucoma picture isn't straightforward.
As we wrap up our review of the ocular adnexa, it's important to consider the effects that glaucoma medications themselves can have on periocular structures. Prostaglandin analogs, one of the most commonly used drug classes in glaucoma management, can lead to a number of changes over time. These include increased periocular pigmentation and longer eyelashes, often noticed by patients. More significantly, they can cause periorbital fat atrophy, resulting in a sunken appearance of the eyes, or an ophthalmos. There may also be deepening of the eyelid sulcus, eyelid tightening, and even mild ptosis. Altogether, these changes can affect inferior scleral show and alter the natural eyelid contour, which can be cosmetically concerning for some individuals. So, while prostaglandins are effective, these local side effects should be kept in mind during long-term therapy. Moving forward, let's talk about the role of pupillary function in glaucoma. Assessing the pupils is an easy but powerful way to evaluate glaucoma severity and monitor for effects of surgery or treatment. Certain medications, like parasympathomimetics and adrenergic agonists, can alter pupil size and must be considered when interpreting findings. One key thing to look for is a relative afferent pupillary defect, or RAPD, which often appears in asymmetric glaucoma. But if you see an RAPD and the glaucoma doesn't explain it, think about other optic nerve pathologies. If it's hard to assess clinically, a brightness comparison test can help confirm it. Now let's move on to slit lamp biomicroscopy, a core part of every glaucoma exam. This tool allows detailed examination of the conjunctiva, cornea, and anterior chamber, helping identify glaucoma-related signs, guiding surgical planning, and monitoring post-op changes. It's especially useful for picking up subtle findings on the external eye, like changes in conjunctival vessels or filtering blebs that may hint at disease activity or complications. Continuing with the slit lamp exam, we focus now on the conjunctiva and how it's impacted by intraocular pressure and long-term medication use. Chronic IOP elevation and topical therapy can lead to hyperemia, follicular conjunctivitis, reduced tear production, and scarring. Alpha-2 adrenergic agonists are particularly known for triggering allergic responses. If a bleb is present, it should be carefully described by its size, shape, location, elevation, vascularity, and thickness. Don't forget the Seidel test, essential for detecting aqueous leaks using fluorescein. Now turning our attention to the episclera and sclera, important structures that can reflect underlying glaucoma processes. Dilated episcleral vessels may point to elevated episcleral venous pressure, whether idiopathic or secondary. Keep an eye out for sentinel vessels. These could indicate an intraocular tumor, potentially causing unilateral glaucoma. It's also crucial to assess for scleral thinning or the presence of a staphyloma. And don't overlook slate-gray pigmentation in oculodermal melanosis, which heightens the risk for both glaucoma and ocular melanoma. Lastly, scleritis may be another contributor to increased intraocular pressure. Let's now review corneal findings relevant to glaucoma evaluation. In pediatric glaucoma, Hobbs stria, breaks in Descemet's membrane, are a key sign. Toxic drug reactions may show up as punctate epithelial erosions, while acute high IOP often leads to microcystic epithelial edema. The corneal endothelium can also provide important secondary clues. Look for Krukenberg spindles in pigment dispersion, pseudoexfoliative material, stellate chorotic precipitates in herpetic uveitis, vesicular endothelial changes in posterior polymorphous dystrophy, and the hammered silver appearance seen in ice syndrome. Don't forget to assess for surgical or traumatic corneal scars, which can be associated with glaucoma. Finally, measuring central corneal thickness is critical. Thin corneas not only increase glaucoma risk, but they also cause IOP underestimation during tonometry. Now, focusing on the anterior chamber, this structure plays a critical role in glaucoma. Start by evaluating its depth and shape. The Van Herrick method is a quick way to estimate angle width, but it may miss some cases of angle closure. That's where gonioscopy becomes essential for definitive assessment. Several patterns hint at angle closure mechanisms. A shallow peripheral chamber might be seen with iris bombay or plateau iris. Malignant glaucoma and other posterior pushing forces can lead to shallowing of both the central and peripheral chambers. During acute IOP spikes, corneal edema might obscure your view on gonioscopy. In those cases, the fellow eye often offers helpful clues. Finally, pigment dispersion syndrome features a deep anterior chamber with a concave iris. Mechanical rubbing of the iris against the lens zonules releases pigment, which can clog the trabecular meshwork and raise IOP. Watch for pigment, inflammatory debris, and flare before starting any drops. When examining the iris, always do so before dilation. This allows you to detect key features that could be masked later. Start by noting heterochromia, which may suggest Fuchs or melanoma. Look for iris atrophy, a hallmark of ice syndrome or past trauma. Ectropium uvea can be congenital or linked to neovascular glaucoma. Don't miss correctopia, often seen with ectopia lentis or trauma. Nevi and nodules may point towards syndromic or inflammatory conditions like NF1 or uveitis. You should also check for pseudoexfoliative material, transillumination defects from pigment dispersion, and the patency of iridotomies or iridectomies. Finally, be mindful of any surgical alterations to the iris structure.
Let's continue with the clinical significance of the iris. Always document iris color. This is especially important before starting prostaglandin analogs, which may darken the iris.
Watch for rubeosis or neovascularization, as it can be an early sign of ocular ischemia or advanced glaucoma. Be alert for signs of prior trauma, sphincter tears, iridodialysis from root disruption, or iridodenesis, which is the iris trembling from weak zonules. Any abnormal contour should raise concern for pigment dispersion, cysts, melanoma, or choroidal disease. Ultrasound can be a helpful adjunct to evaluate deeper iris or ciliary body lesions that aren't visible clinically. Now we move on to lens evaluation. You'll want to assess the size, shape, clarity, and stability of the lens, along with the appearance of the anterior capsule, both before and after dilation. These findings can help identify lens-related causes of glaucoma. Pay close attention to signs like lens opacity, posterior capsulopacification, or subluxation. Look for posterior subcapsular cataracts, which are often associated with steroid use. After dilation, check for pseudo-exfoliative material, and don't overlook rust-colored epithelium. It may suggest siderosis from a retained intraocular foreign body. Let's talk about gonioscopy, your go-to technique for evaluating the anterior chamber angle. It's the gold standard for determining whether the angle is open or closed, and it helps detect angle recession or peripheral anterior synechia. Without a gonio lens, total internal reflection blocks your view of the angle. But using a plastic or glass gonioscopy lens bypasses that by eliminating internal reflection at the corneal air interface. You'll need a coupling agent like tears, saline, or methylcellulose to make proper contact. Just remember, bright lights can cause miosis, which might artificially widen the angle and mislead your assessment. Let's compare the two main techniques of gonioscopy. Direct gonioscopy uses direct view lenses like Kopy, Barkin, or Swan-Jacob and is done with the patient lying down. This setup is ideal for surgeries or examining infants. The key advantage is it provides a real, upright view of the angle. In contrast, indirect gonioscopy is more commonly used in the clinic. It's performed at the slit lamp with the patient upright, using lenses like Goldman or Zeiss. The image appears inverted and foreshortened, and you view the opposite angle quadrant. This is the normal gonioscopy view of the anterior chamber angle. From posterior to anterior, we first see the ciliary body band, labeled as structure 2, followed by the scleral spur at number 3. Just anterior to that is the trabecular meshwork, divided into posterior 4A, mid 4B, and anterior 4C regions. At the most anterior edge is the Schwabe line, labeled as number 5. This marks the termination of Descemet's membrane. The wedge-shaped reflex marked by the asterisk is the corneal wedge, which helps identify the Schwabe line during gonioscopy. Lastly, the peripheral iris is marked as 1, and the angular approach, insertion, and curvature are represented by C, A, and B respectively. Understanding this anatomy is critical when evaluating angle structures in glaucoma. The 4-mirror gonioscopy lens, such as Zeiss, Posner, or Sussman, allows quick, efficient angle evaluation. These lenses provide a 360-degree view without needing to rotate the lens, and don't require viscous coupling fluid, making them ideal for clinic use. We also use these lenses to perform dynamic gonioscopy or indentation gonioscopy. By applying gentle pressure posteriorly, we test the angle's flexibility. If the angle deepens, the closure is likely appositional, from pupillary block or plateau iris. If the angle remains closed, it suggests peripheral anterior synechia, or PAS. Dynamic gonioscopy is essential for distinguishing the mechanism of angle closure, which directly impacts treatment decisions like iridotomy versus lens extraction. When performing gonioscopy, use dim lighting and a thin light beam to avoid artificial opening of the angle. Begin by identifying key landmarks. The scleral spur, which sits between the ciliary body face and pigmented trabecular meshwork, and Schwalbe's line, which is best found using the corneal wedge technique. This technique uses two reflections from the internal and external cornea that meet at Schwalbe's line. Always examine the entire angle in a systematic fashion. Start inferiorly, as this area is usually wider and makes landmark identification easier. Proper documentation depends on accurate visualization and methodical inspection. Let's talk about angle closure and grading in the context of gonioscopy. In angle closure, the iris blocks the trabecular meshwork, making it no longer visible on exam. Dynamic gonioscopy plays a critical role here. By applying gentle posterior pressure, you can distinguish between appositional closure, where the iris is simply in contact with the meshwork, and synechial closure, where the iris is permanently adherent to the angle structures. There are two systems commonly used to grade the angle. The Schaefer system assigns a grade from 0 to 4 based on the angle width. A grade of 1, which corresponds to approximately 10 degrees, indicates a high risk of angle closure. The Spaeth system is more detailed. It evaluates the iris root insertion using labels A through E, describes the angular width in degrees, and characterizes the iris configuration as concave, bowing, plateau, or flat. It also accounts for the amount of pigmentation in the trabecular meshwork on a scale from 0 to 4+, and notes the presence of peripheral anterior synechii. Together, these grading systems provide a comprehensive understanding of angle anatomy and are essential in identifying the mechanism and risk level of angle closure. In this slide, we'll explore blood, vessels, peripheral anterior synechii, and pigment as seen on gonioscopy. Schlemm canal is typically not visible unless there is blood reflux, which may occur with elevated episcleral venous pressure or hypotony. Abnormal angle vessels can arise in conditions such as neovascularization or Fuchs uveitis syndrome. Vessels that cross the scleral spur to reach the trabecular meshwork are almost always pathologic, and the associated contracted myofibroblasts can form peripheral anterior synechii. It's also important to differentiate normal iris processes, which are thin and lacy, from pathologic PAS, which appears solid and sheet-like. Regarding pigment, you'll see more with increasing age and in individuals with darker irises. Pigment also tends to accumulate after ocular surgeries, trauma, inflammation, or in the setting of hyphema, melanoma, or angle closure. Pigment deposition is usually segmental and more prominent inferiorly, but it can increase superiorly in later stages of pigment dispersion syndrome. Lastly, the Sample-Lazy line represents pigment anterior to Schwalbe's line and is a classic sign of pseudo-exfoliation. This image shows blood in Schlemm's canal, which becomes visible only under specific conditions. Normally, Schlemm's canal is invisible during gonioscopy. However, when episcleral venous pressure rises or with hypotony, blood may reflux into the canal, making it detectable. The fine red line you see in the angle here is that refluxed blood. It's a subtle but important finding that can indicate elevated venous pressure or low intraocular pressure. Recognizing this can help you better interpret the hemodynamic status of the eye during your exam. Now let's take a closer look at neovascularization of the angle. On gonioscopy, you may notice fine, abnormal vessels coursing across the angle structures. These vessels often arise in ischemic conditions like proliferative diabetic retinopathy or central retinal vein occlusion. They may initially appear subtle, but can progress to form a fibrovascular membrane that contracts over time. This contraction can lead to peripheral anterior synechii permanently closing the angle and elevating intraocular pressure. Early recognition is key. In this image, arrows highlight these fine neovascular tufts crossing the trabecular meshwork, an appearance you should be able to recognize clinically. This slide shows examples of angle pigmentation observed during gonioscopy.
Pigmentation within the angle can vary widely and is influenced by multiple factors. It tends to increase with age and in patients with darker irises, particularly in the inferior angle. You'll also see greater pigment following trauma, inflammation, angle closure, and surgical procedures. The image on the left shows a clearly defined line of pigment just anterior to Schwab's line, known as a sample lazy line. This finding is classically associated with pseudo-exfoliation or pigment dispersion. On the right, we see heavy trabecular pigmentation distributed in a dense band-like pattern, which should raise suspicion for pigment dispersion syndrome or prior inflammation. When evaluating angle pigment, always document the degree, distribution, and whether it correlates with other clinical findings. Trauma and other pathologies can leave distinct signs on gonioscopy. One of the most important findings after blunt trauma is angle recession, which appears as a widening of the ciliary body band. You may also see increased prominence of the sclerospur, torn or absent iris processes, and variation in angle depth across the quadrant, all signs of structural damage to the angle. A cyclodialysis cleft refers to a separation between the ciliary body and the sclerospur. This can result in chronic hypotony due to abnormal aqueous outflow into the suprachoroidal space. Other gonioscopic findings include surgical clefts from prior trabeculotomy or goniotomy, inflammatory precipitates, intraocular lens haptics or drainage devices, and space-occupying lesions such as hyphema, hypopyon, iris cysts, or tumors. You may also encounter retained foreign material, abnormalities at the sclerostomy site, or zonule dehiscence after dilation, all of which may alter the configuration or integrity of the angle. Now, let's review the images on the slide. In the top image, you're looking at a side-by-side comparison of a normal angle versus one that has undergone angle recession. Note the expanded ciliary body band and deepened angle on the right side, classic for post-traumatic recession. In the bottom image, multiple features are labeled. A marks a cyclodialysis cleft, visible as a darkened gap between the ciliary body and sclera. B indicates peripheral anterior synechii and pigment changes, likely due to previous laser or inflammatory damage. C shows angle recession again, this time between the black arrowheads, with visible widening and loss of iris processes. These gonioscopic findings are important not just for diagnosis, but also for determining prognosis and guiding treatment decisions in both trauma and surgical patients. This slide summarizes 4 distinct types of anterior chamber angle injuries, which may be encountered after ocular trauma. Let's briefly walk through each type and its appearance on gonioscopy. First, angle recession. This injury results from a tear between the longitudinal and circular muscles of the ciliary body. On gonioscopy, it appears as a widened ciliary band. This is a classic post-traumatic finding and can be associated with secondary angle recession glaucoma. Next is a cyclodialysis cleft. This occurs when the ciliary body separates from the scleral spur, allowing aqueous humor to abnormally drain into the suprachoroid space. On gonioscopy, it is seen as a deep cleft with widening of the suprachoroid space. Clinically, this is often associated with hypotony. The third injury is iridodialysis, which involves a tear at the iris root that detaches it from the ciliary body or sclera. On gonioscopy, this presents as a gap at the iris root and may appear clinically as a peripheral iris defect or result in monocular diplopia. Lastly, there is trabecular meshwork damage. This injury causes a tear in the anterior trabecular meshwork, forming a flap that remains hinged at the scleral spur. Gonioscopy reveals a ragged, irregular appearance of the meshwork, sometimes with pigment dispersion or scarring. Looking at the diagrams on the right, panel A shows the widened ciliary body band in angle recession. Panel B demonstrates a cyclodialysis cleft with an abnormally deep space. Panel C illustrates the iris root tear of iridodialysis. And Panel D depicts disruption of the trabecular meshwork with the flap and pigmentary irregularity.
Each of these findings on gonioscopy can have important diagnostic and prognostic implications, particularly in the setting of trauma.
Ultrasound biomicroscopy, or UBM, uses high-frequency ultrasound between 35 and 60 MHz to visualize anterior segment structures that cannot be adequately seen with a slit lamp exam. This includes the anterior chamber angle, the iris and ciliary body, and any implanted devices that are poorly visualized otherwise. UBM is particularly useful in eyes with corneal opacities that prevent evaluation with gonioscopy. It also helps clarify mechanisms of pigment dispersion when the etiology is unclear. Common structures assessed with UBM include plateau iris configuration, choroidal effusion, cysts, or tumors. It's also useful for imaging glaucoma drainage devices and intraocular lens haptics. Additionally, it can detect retained lens material or intraocular foreign bodies. Now that we've introduced the clinical uses of UBM, let's take a closer look at how it works. Ultrasound biomicroscopy uses high-frequency probes, typically between 35 and 60 MHz, designed to image the anterior segment in fine detail. This is in contrast to conventional ultrasound, which uses lower frequencies around 10 to 20 MHz. For optimal imaging, a fluid-filled probe cover is necessary to allow for acoustic coupling, and the probe must be positioned close to the eye, usually within about 5 millimeters. Because of its high frequency, UBM offers excellent resolution, ideal for fine anterior structures, but its trade-off is shallow penetration, which limits its use to more superficial ocular anatomy. Building on what we just discussed, UBM is especially useful in evaluating angle closure mechanisms. While synechii and slit lamp exams provide surface-level information, UBM complements gonioscopy by allowing us to visualize structures that aren't otherwise accessible. Most importantly, the scleral spur. Identifying the spur is crucial for judging the degree of angle crowding. UBM helps us infer the underlying mechanism of angle closure by assessing several key features: iris contour and thickness, the position and rotation of the ciliary body, anterior chamber depth, lens vault, and lens thickness. There are also quantitative tools that enhance UBM analysis. These can measure iris thickness, lens vault, and angle opening distance. However, it's important to note that these tools still require manual identification of the scleral spur to ensure measurement accuracy. Figure 411 illustrates two examples of UBM imaging. Part A shows a plateau iris configuration, where the image demonstrates a narrow angle caused by the plateau iris. Key anatomical structures are labeled: S for sclera, C for cornea, AC for anterior chamber, I for iris, CB for ciliary body, PC for posterior chamber, L for lens, LC for lens capsule. The arrow in the image points to the scleral spur. Part B demonstrates secondary angle closure. In this image, the angle closure is caused by a peripheral iris pigment epithelial cyst, as indicated by the arrow. The slide notes that this cyst causes mechanical obstruction of the angle. Now that we've covered the advantages of UBM, let's briefly compare it to another common anterior segment imaging tool, ASOCT. Anterior segment optical coherence tomography offers rapid, non-contact imaging of the anterior chamber, including the angle. It provides high-resolution images, but this comes at the cost of limited depth penetration. There are several key limitations to keep in mind. First, ASOCT cannot visualize the ciliary body or sulcus, which is a major advantage of UBM. It also frequently fails to clearly define angle landmarks, particularly the scleral spur. Another important limitation is that ASOCT cannot distinguish between appositional angle closure and closure caused by synechii. This differentiation requires dynamic gonioscopy. Finally, the accuracy of ASOCT is highly dependent on the examiner's interpretation and patient cooperation, making it more subjective compared to UBM.
Let's wrap up our discussion on ASOCT by highlighting some important clinical considerations. One major challenge with ASOCT is landmark detection, specifically identifying the scleral spur. This can be difficult, and when it isn't clearly visualized, it can significantly impact the accuracy of any measurements we rely on. Despite this limitation, ASOCT still offers meaningful clinical value. It's particularly helpful in detecting angle closure, and it can generate quantitative parameters similar to those from UBM, like angle opening distance, AOD, iris thickness, and trabecular iris space area. In addition, 3D ASOCT allows us to detect and quantify iridotrabecular contact, offering a more complete view of angle relationships. Finally, it's a valuable tool in the pre- and post-operative assessment of cataract surgery, helping us understand changes in the anterior segment configuration. To summarize the key differences between UBM and ASOCT imaging, here's a side-by-side comparison. UBM, which uses ultrasound, has a resolution of about 25 to 50 microns, and it can penetrate pigmented tissue, which is critical in certain angle evaluations. However, it requires acoustic coupling, meaning a fluid interface, and demands more technician skill. The process is generally slower. In contrast, ASOCT uses optical technology and offers higher resolution, around 5 to 30 microns, but it does not penetrate pigment, which limits some views. It is non-contact, requires no coupling, and is much faster and easier to perform with less skill required. This comparison helps guide which modality to choose based on clinical context. This slide outlines the key quantitative parameters obtained from anterior segment imaging using either UBM or ASOCT. First, under angle configuration measurements, we have AOD 500 and AOD 750. These refer to the angle opening distance measured at 500 and 700 microns from the scleral spur. TI, the trabecular iris angle. TISA 500, or trabecular iris space area at 500 microns. ARA 500, the angle recess area, also at 500 microns. These measurements help quantify how open or narrow the angle is. Next, we move into iris and lens relationships. IT 750 and IT 2000 measure iris thickness at 750 and 2000 microns from the scleral spur. ICPD stands for iris ciliary process distance. ILCD is the iris lens contact distance. TCPD measures the trabecular ciliary process distance. These values help characterize structural contributors to angle closure. Finally, under anterior chamber dimensions, ACD is anterior chamber depth, ACW is anterior chamber width, ACA is anterior chamber area, and LV, or lens vault, refers to the vertical distance between the lens and a line drawn between the scleral spurs. Each parameter is also illustrated in the diagrams to the right, which help visualize exactly where these measurements are taken. This slide covers specular microscopy, which is a non-contact, non-invasive imaging modality used to assess the corneal endothelium. Its primary purpose is to automatically evaluate two key parameters: endothelial cell density, or ECD, and endothelial cell morphology. Clinically, specular microscopy is especially useful in monitoring ECD loss in patients who have implanted glaucoma devices. This loss can occur as a result of mechanical trauma or from changes in aqueous flow patterns caused by the device. It also plays a diagnostic role in posterior corneal disorders, such as posterior polymorphous corneal dystrophy, abbreviated PPC, and in ICE syndrome. In disease states, specular microscopy may reveal a reduced endothelial cell count and a loss of the normal hexagonal cell shape, which are both indicative of endothelial dysfunction. That brings us to the end of this section. Thanks for your attention. Take a moment to review any areas that felt unclear, and when you're ready, move on to the next topic. Please review the questions we have provided at the end of the video.